Today we're going to talk about chapter 47, which is the role of sonography in obstetrics. So we have moved on to the OB chapters in your book, and we are done with the gynecology chapters. This is an overview of why we do obstetric sonography. So it's pretty interesting, but we will go into more detail in the next couple of chapters of each different trimester scan. For the introduction, basically it's just talking about that sonography is the primary tool for evaluating the developing fetus during pregnancy. The reason is ultrasound is considered relatively safe for a fetus, and the benefits outweigh the risk when it comes to sonography with a fetus, because we can evaluate how the baby is growing, if everything with the fetal development is well, and the well-being of the baby. If there is an abnormal condition with the fetus, a lot of the times they can manage it better if they know exactly what's going on. If a baby needs heart surgery right out after delivery, they can be in a certain center that does that. Or if a baby has some other kind of abnormal growth pattern, we can keep watching it to make sure that they're still doing well in the womb. So sonography is definitely a very good tool to use when we're monitoring pregnancies. Sonographers must accurately and thoroughly compile pertinent information. And what that means is basically, I'll teach you how to do measurements and what to look for in each scan to make sure everything looks well with the baby. And then we write up a report and give to the doctor itself. We have guidelines that tell us what our protocols are, and these are from the ACR, the AIUM, and the ACOG, and it recommends specific components of examination, just like your protocols that you've had with all the other things. There is also protocols for first and second and third trimester scans. Multiple indications are used for obstetric sonography. The first one, probably the earliest indications why we do it, is to estimate the gestational age. Usually, if a patient does not have late prenatal care and comes in on time for their scans, they'll come in to the doctor around 8 weeks, and the doctor usually wants to scan to make sure that the fetus is viable, and also to measure the crown rump length, which is the head to the booty of the little baby, to give an estimated date of delivery. The first trimester's crown rump length is the most accurate measurement that you're going to do during obstetric scan. So it's more accurate than all of our measurements that we do in the second and third trimester. Another indication is evaluation for fetal growth. If a patient comes in for small for gestational age, or the mom has an underlying growth condition, we will want to measure the baby in multiple different ways: the head, the belly, and the femur, and that will give us an estimated fetal age, which we are trying to see if it matches up with what the estimated due date should be. And we'll go into this more in the upcoming chapters. If a patient has any kind of vaginal bleeding, that is a cause for concern sometimes, and so they want to, that would be an indication for doing a scan to just make sure that the baby is still viable, or if there's a subchorionic hemorrhage or something that's causing the bleeding. If a patient has an incompetent cervix, they'll want to evaluate the cervical length. If a patient has pain or abdominal pain, they'll want to also do a scan for like a possible ectopic pregnancy, an abruption of the placenta, or other kind of things that could be going on, a fibroid or different masses. If they're not sure if the patient is, or the fetus is head up or head down, which is fetal presentation, they'll do an ultrasound to tell if the baby is in the right position before they deliver the baby. If there is a suspect of multiple gestations based on fetal heart rate or the fundal height of the mom is bigger, or fertility drugs, they'll do an ultrasound to make sure that there's just one baby in there. If they have amniocentesis or CVS, which we'll talk about a little bit later, they'll do an ultrasound for that. If there is a significant discrepancy between uterine size and clinical dates, they'll do one for that. That will help to rule out conditions such as oligohydramnios, which is low fluid, polyhydramnios, which is increased fluid, along with multiple gestations, intrauterine growth restrictions, or anomalies. If there's a pelvic mass, they'll want to look for that and to see how big it is. If a patient could potentially have a high datiform mole that's suspected because of hypertension, proteinuria, ovarian cyst, which we'll talk more about what that is later on. If a patient has had a cervical cerclage, which happens, they kind of tie up the cervix, sew up the cervix, so that if a patient has a known incompetent cervix, this will help the baby stay in as long as it needs to. If there's an ectopic pregnancy, they would. If there is a suspected fetal death, we would do an ultrasound. If there's a uterine anomaly, abnormality like leiomyoma and bicornuate uterine didelphys, they'll do an ultrasound for that. If they're concerned about the baby's well-being, they will do a biophysical, which is just another type of scan. If there's a suspicion of polyhydramnios or oligohydramnios, they'll do a ultrasound for that. Placental abruption, an aversion, estimated fetal weight and presentation. So you're seeing that there's a lot of reasons why we do these ultrasounds. If a first trimester markers come back that the baby could potentially have some kind of trisomy, they will do an ultrasound for that. If we are following up on a certain fetal anomaly, we'll do ultrasound. If we're following up on a placental location, we'll do ultrasound. If a patient has late prenatal care and doesn't come in on time, we'll do an ultrasound. To assess for aneuploidy, which is basically a chromosome abnormality, or to do a nuchal translucency scan. These are all things that you're going to learn about. So as we went through that list, you can tell and see that there is a lot of reasons why we do ultrasounds on a baby. And it just is such a helpful tool to assess the fetal well-being. We do multiple different kinds of scans. We could do just a limited scan. If a patient just comes in and they want to see where the placental is, and that's it. We'll just do a limited ultrasound for placenta. We do a standard scan. Now, this is the one that you guys mostly know from Gender Reveals, which you'll get the pleasure of being able to do those for patients a lot. But a standard scan basically is where they come in from 18 to 20 weeks, and we just make sure everything looks good with the baby. They get to find out the gender at that time if they want. Or there's a specialized scan. And I also do these at where I work because I work for maternal fetal medicine. So if something is off on the standard scan or they suspect some kind of anomaly, they will send a patient to a maternal fetal medicine doctor who specializes in these kind of things, and we'll do a specialized scan, which is like more of a detailed scan of the baby. So like I said before, like with the standard exam, that usually occurs 18 to 20 weeks. I like to have the babies there at 20 weeks because it's a little bit easier to see everything than 18. But the standard exam includes the evaluation of gestational age by fetal biometry, which is just the measurements that we do on the baby, the fetal number, how the baby's laying, where the placenta is, cardiac activity, amniotic fluid, and then we'll do a fetal anatomic survey, including all the elements specified in the guidelines. We might look at the cervix and adnexa when appropriate. If they want to see the cervix a little bit better, they might recommend a transvaginal scan because that's the best way to evaluate the length of the cervix. A limited exam is a 76815. That's the code, which you don't need to know that at this time. But that's just when a doctor wants to look at a specific thing. He thinks that the placenta might be in a lower location than it should. Then he would say limited ultrasound for placental location. And we will just look at that, and we won't do a full anatomy screen. A lot of the times we do repeat scans, which is after the standard obstetric examination, to evaluate growth later on, second and third trimester growth. If we weren't able to see the heart very well on the standard scan, sometimes the patient will come back. Well, most of the time the patient will come back and we'll evaluate the heart if the baby's in a better position when baby's a little bit older and can be seen better. And these are called repeat ultrasounds, growth ultrasound, 76816. The specialty obstetric sonography examination is a 76811, and it's called like a targeted or detailed exam. So when a patient comes in and they're suspecting like a heart defect, we will do another exam with basically the same stuff, maybe a little bit closer look at the heart, more heart views. But what we will charge a 76811 because it's a little bit higher of an exam than a standard exam. And this is basically all we talked about there. You'll do first trimester exams, and this is the CPT code is 76801, and it's performed before 13 weeks, 6 days of gestation. And you'll kind of do like what you would do for a pelvic ultrasound. So you do your uterus, cervix, maternal adnexa, but on top of that, you'll look at the uterus for the gestational sac and the embryo and do a heart rate, and you will measure the embryo, and that'll give you a good gestational age. You'll be able to see anomalies, uterine anomalies, easier in the first trimester than you will in the second trimester. So if a patient comes in with a uterine didelphys or 2 uteruses, if you remember, that'll be more easy to evaluate in the first trimester. Another thing that's easier to see is the multiple gestations are easier to see in the first trimester to determine the chorionicity and the amniosity. And basically that's saying, are they fraternal? Are they identical? The reason we can tell that is because of how many gestational sacs they have versus how many placentas they have. And it's just easier to see in a first trimester. Again, we'll go over this in more detail in the upcoming chapters. We also do what is called a nuchal translucency exam. These, we still do quite a few of these. Some places don't as much because there is also a blood test in the first trimester that will give them a risk of how much the baby has of potentially having a chromosome abnormality. And the same with this exam. We'll look at the back of the neck and measure it, plus blood work, to determine if a baby has a higher chance of having a trisomy, potentially trisomy 21, 18, and 13. So you want to make sure that you take a lot of patient history when you're doing an ultrasound. Open-ended questions such as, do you have any concerns? If they do, then they'll let you know. But you also want to make sure that you do closed questions like, when was your last menstrual period? That determines how far along the patient should be in their pregnancy, which is a huge part of gathering information. You'll also ask, how many times has the patient been pregnant? So this is what we call gravida and parent. Gravida, and you need to know this for your test. So the Gravida, G, is the number of pregnancies, including the present one. So for me, let's say I was pregnant 3 times. So my Gravida would be 3. Parity is the reported using a numeric system that describes all possible pregnancy outcomes. So the letter P is followed by 0, 0, 0, 0. So how it looks is it goes in order. So full term deliveries, premature births, and stillborns, early pregnancy loss or termination, and then living children. So that's how it looks. So how many times this patient has been pregnant? She's going on her 4th pregnancy. She's had 2 full-term deliveries, 1 premature birth, no early pregnancy losses, and 3 living children. So my Gravida pair would be Gravida 3. I was pregnant 3 times. I had 3 full-term deliveries, no premature deliveries, no early pregnancy losses, and I have 3 living children. And this is how we'll write this in our report so that the doctor knows their history. You'll also want to calculate the clinical dates. So we'll usually go from the first date of the last normal period. And that's a standard way to date pregnancies in the United States. So the human pregnancy lasts 266 days, plus or minus 10 days. So if a conception occurs on day 14 from LMP, the pregnancy duration is 280 days or 40 weeks. So the funny thing is for your first 2 weeks of your pregnancy, how we determine it, you're not even pregnant, right? Because conception occurs on day 14. But that's just the easiest way for us to chart it. And most people can remember their last menstrual period. So it's just how we do it in the US. So the pregnancy is divided into trimesters, approximately 13 weeks each. So a pregnant woman in the first trimester is pregnant until 13 weeks, 6 days gestational age, which most people, when they get out of the first trimester, can breathe a sigh of relief because miscarriage rate goes down quite a bit. The second trimester is between 14 weeks and 26 days, 26 weeks, 6 days. And the third trimester begins at 27 weeks. That's what this book says. Some places say 28 weeks. So it kind of depends, but 27 to 28 weeks is when the third trimester begins. And that lasts until 3rd term. In reality, the assessment of gestational age is often not precise. Many women have irregular periods, conceive within 3 months of coming off birth control, when ovulation is regular, and do not record dates. Even with known menstrual date, sometimes conception won't occur exactly when they think. So the difference could be up to 3 weeks in gestational age. But the LMP gives us the best bet of what the potential date of delivery could be. If a patient doesn't remember their last menstrual period, I bet they know their estimated date of delivery from what their doctor has said. So if they're like, oh, I can't remember, that was so long ago, just be like, okay, so when is your due date? And that is always easier for them to remember. The sonographer should not change the estimated due date or redate the pregnancy once an earlier sonogram has established gestational age. So dates established by sonography performed in the first or second trimester typically take precedence over menstrual dates when the discrepancy is greater than 7 days in the first trimester or greater than 10 days in the second trimester. So let's say a patient comes in and says, my last menstrual period was March 1st. And at this time, that would put the patient at around 10 weeks. Well, we do an ultrasound and we see that the baby looks viable, and the heart rate looks good and everything's looking great, but you're only measuring 8 weeks. So because we are off by 2 weeks, we are allowed to change the due date because her dates were probably just off. Does that make sense? I hope. The same thing in the second trimester, if the patient is off by greater than 10 days, usually we can change the due date because the dates have been off. And that's just what I kind of said before. So here's, I don't know, I call them Najeel's rule. But it's kind of interesting. So your LMP minus 3 months plus 7 days is the estimated delivery date. LMP equals estimated date of confinement plus 3 months minus 7 days. So it's kind of interesting how they've made this out. So for example, LMP of 1017 would result in an estimated due date of 724. So 1017 minus 3 months would be 717 plus 7 days, 724. Granted, you don't have to figure this out by yourself because we have computers that you put in the LMP and then it will calculate the estimated due date for you. So this is just more an interesting little tidbit because you will be able to get it calculated, and our machines do it. So I'll show you how to do that. The sonographer needs to know if a patient currently taking any medication or has experienced clinical problems with pregnancy, such as bleeding, decreased fetal movement, or pelvic pain. So you'll want to ask if they've had any problems with their previous pregnancies. So like incompetent cervix, fetal macrosomia, growth restriction, a chromosomal abnormality, all this information needs to be documented in the report. The sonographer needs to know if a patient has maternal risk factors for anomalies that may impact examination or interpretation. So we want to know if a patient has a higher risk of having a chromosomal abnormality, because that will kind of focus us in a little bit more when we're doing the scan of some of the things that we need to look for with that. If a patient has maternal disease such as diabetes or lupus, they have a higher chance of multiple different anomalies. So just knowing this kind of information will kind of help us to kind of zone in on what we need to look at. Like with diabetes, a patient has a higher risk of multiple different things. One of those things, type 1 diabetes for sure, is a heart defect. And so not that I would never, I would do the same heart views, but I might pay a little bit more attention to the heart if a patient that has type 1 diabetes, and maybe take some more views of the heart in different ways just to make sure, because they have a higher chance of that. So knowing those kind of things before you go in and start scanning is a huge thing. If a patient has a history of a baby born with trisomy like trisomy 21, which is Down syndrome, they have a higher chance of that happening again. So that just is good information to have. So you can start looking to see if they are having the same kind of, if there's anything that's sticking out that could potentially say that this baby might have the same trisomy. Now, the safety of ultrasound. There are theoretical effects of ultrasound energy on the fetus, but there are potential biological effects that have not been documented. So we don't want to just like keep scanning and scanning and scanning and scanning, because we're trying to reduce the amount of ultrasound. You want it to be a great exam. You want to make sure that you get everything, but you also don't want to overdo it. So the energy produced by ultrasound equipment today is higher than produced earlier equipment, and Doppler imaging, so like pulse wave Doppler, has higher energy. So there's just stuff that you just don't want to continue to do if you don't have to. That the studies of ultrasound bioeffects are not definitive, and continued research is essential. So it's our responsibility to have knowledge regarding ultrasound bioeffects and to use the least amount of energy necessary to produce clinical information. We call this ALARA, as low as reasonably achievable. So we try to, the potential benefits and risk of each examination should be considered. The LARA principle should be observed when adjusting controls that affect the acoustic output and by considering transducer dwell time. So you don't want to stay on one part of the baby forever and ever. You want to just continue to do your scan, but just be present and knowing that, you know, you are scanning it. The bioeffects are probably fine. You know, they've done studies, they haven't seen anything yet, but you know, you are doing something outside to the fetus. So you just want to be careful with how much ultrasound you give the baby. The Doppler ultrasound provides non-invasive method to assess physiology and pathophysiology of the fetal and maternal circulations, which is good. Sometimes we need that. If we have a patient that has a risk of intrauterine growth restriction, we need to do Dopplers of the cord to make sure that the blood flow from the placenta to the baby and the baby to the placenta is good. And that's important. And that's a benefit that's outweighing the risk of what the Doppler ultrasound could potentially do. But we just don't want to, again, overdo it. Now, I have to say something. Do not, and I do not teach that we do pulse wave Doppler ultrasound during the first trimester. So let's say a baby comes in, or a patient comes in, and the baby is 5 weeks, 4 days. That little heart has just started beating, just started. And the Doppler, to hear the ultrasound, is such a high energy level for this little heart that's just started beating that I do not teach my students that we should do pulse wave Doppler on a little heart in the first trimester. Not that anything has been known, but it's just such a tiny little developing little baby that it's just not worth putting extra energy into that from the pulse wave into the little baby that's just trying to get that heart to develop. So to document the heart rate, what we do is M mode, which I'll show you guys that too. And next, and it's just a motion mode. So we just kind of listen, are able to track the heart rate that way, but it doesn't have the as high energy as the pulse wave does in the first trimester. A lot of patients want to hear the heart rate in the first trimester when you're scanning them, but I think I'm like, when anybody asks me, I'm like, I just don't like to put that pulse wave Doppler on a young baby in the first trimester while the heart's developing. And when I say that, all of them understand that, you know, that's the most important thing. So that's just my 2 cents on that. And this is kind of what we talked about before. So it's important that all our sonographers strive to consistently meet or exceed minimum standards during every obstetric sonographic examination. You want to be board certified, which you guys are going to get right when you get out of school, and you become a registered diagnostic medical sonographer. So you have gone through the registries and you are an expert at obstetrics and gynecology, and you can assure the public that the person performing the sonogram has necessary knowledge, skills, experience to provide the service. It's a huge thing. The documentation guidelines recommend that there is a permanent record maintained of measurements and anatomic findings. Images need to be labeled with patient's name, date, image orientation if appropriate. The written report of examination must be maintained in patient records. Transducer frequency and selection and equipment settings should be balanced, optimal imaging resolution and penetration. And you remember we're trying to strive for a LARA, which is low as reasonably achievable. So we want it to be a great exam, but we also we want to limit our exposure. So with the first trimester scan, you're either going to do a transabdominal or transvaginal ultrasound, depending on how far along the mom is. I'd say like around 5 to 6 weeks, it's so much easier to see transvaginally. Once the baby is 7 weeks, 8 weeks, you can tell transabdominally, you can see the fetus pretty well. But early scans, transvaginal is the best way to see. Transabdominal examination may provide an overview of entire pelvic cavity, enable the sonographer to visualize the uterus from cervix to fundus, evaluate the ovaries, the adnexal areas, look for presence of free fluid. The transvaginal transducer provides more limited view of the pelvic, but is excellent visualization of embryo, yolk sac, amnion, chorion, and gestational sac. So everything that we want to see in the first trimester, I feel like the transvaginal is better, especially earlier on. So I would say from 5 to 7 weeks. Before 5 weeks, you're really not going to see anything transvaginally or transabdominally. So the uterus and adnexa should be evaluated for the presence of gestational sac. If a gestational sac is seen, we want to make sure that it's in the uterus, which is intrauterine. If it's extrauterine, we're talking about an ectopic pregnancy. If there is just a gestational sac but no embryo, it could be too early. So for the embryo to be developed yet. So we will measure the gestational sac to see how large it is. The presence or absence of the yolk sac and embryo should be noted. So first you're gonna, and honestly, you guys, we're gonna go through all this in the next couple chapters. So this is just an overview. So if you're kind of confused, like what's this, what's that, we'll go into more detail about it. So the yolk sac is the first part of, after the gestational sac, the yolk sac is the first thing to show up. And and then a little bit later, the embryo shows up. So seeing a gestational sac and a yolk sac, but no embryo, doesn't necessarily mean that something is wrong. It just means that it's too early for the embryo to be noted yet. The crown rump length is the most accurate measurement of gestational age during the first trimester. And this should be recorded when the embryo is present. So you'll measure from the head to the bottom. But honestly, 5-6 weeks gestation, they just look like a little line. So you just measure the little line. There's a little. And that's kind of what we talked about there. I just want you to know that the bowel herniates from the fetal abdomen around 8 to 11 weeks and then returns to the abdominal cavity. So that's a normal finding in the fetus, but yeah, we'll talk about that a little bit later. So for a sample protocol, you want to confirm cardiac activity. Now, this is something that might be on your test. The cardiac motion usually seen when embryo is 5 millimeters or greater. The fetal heart rate is much faster than the mother's heart rate. So the fetal heart rate starts out slow from like around 90 to 100 when it first starts beating around 5 weeks, 4 days. But then it like starts zooming up there to 180 beats per minute in the when the baby is around 9 to 10 weeks. And then it returns back down to 120 to 160 throughout the rest of the pregnancy. We should look for multiple gestations. You want to count the embryos and yolk sacs to determine multiple pregnancies. You want to evaluate the uterus adnexal structures and cul-de-sac. And during the late first trimester, you could look at the nuchal translucency. So the protocol for the second and third trimester scan would be just a sample. The first thing we want to do is make sure the baby has a good heartbeat. You want to look at the fluid. Now, in the second trimester, when a baby is 18 to 20 weeks, we a lot of the times do like a subjective amniotic fluid volume, which means we look at it and we're like, yeah, that looks good. After 24 weeks of gestation, I like to do a 4-quadrant amniotic fluid index, which is AFI. What that does is it cuts the abdomen into 4 quadrants, and you measure each quadrant. Again, I will teach you all this, so do not be frustrated if this is kind of confusing. The placental location, we want to look at that. We want to see if it's anterior or posterior, or where is the placenta. Sometimes if that urinary bladder is over distended, it can make the placenta look like it's over the cervix, which we call placental previa, which is not something we want. So you'll want to make sure the mom's bladder is not too full. Sometimes we have to do a transvaginal or transperineal ultrasound to document the cervical length. We want to assess the gestational age by doing biometry. Biometry means measuring the baby. We do what a biparietal diameter, which is an axial plane that includes the thalamus and cavum, septum, pellucidum. So we'll measure the head from side to side and front to back. The biparietal diameter is measured from the outer edge to the inner edge of the skull. The head circumference is measured at the same level as the BPD. So we'll measure from side to side, and then we measure around the head like a hat. We'll also measure the femur of the baby and do the abdominal circumference. Then your handy dandy computer will put it all in and do its calculations in its little algorithm, and it'll tell us how far along the baby is. From this, we can get also not only how far along the baby is, but how much the baby weighs. We also want to evaluate the maternal anatomy. So that means looking at the adnexal areas and the uterus, make sure there's no fibroids. Then we want to look at the fetal anatomy. There's multiple different protocols, but we will give you some guidelines of what exactly you need to look at. So in the head and neck, there's all these different things that you look at, and you do it pretty fast. So but the cerebellum, the choroid plexus, the cisterna magna, the lateral cerebral ventricles, the midline falx, cavum, septum, pellucidum, the upper lip, measurement of nuchal fold. We do that all in when we're taking a couple of head measurements and looking at the head. Then we look at the chest. We look for the 4-chamber fetal heart. We look for the left ventricular outflow tract and the right. We want to make sure they're in the right spots. We look at the abdomen. We look at the stomach, the bladder, the kidneys, the umbilical cord, the number of vessels in the umbilical cord, the spine, the extremities, and the gender. Now, the funny thing is when patients come in, a lot of the times they have no idea what we do, to the fact that we don't just take pictures of the baby. We're also examining the baby to make sure that they're okay and they look good, and that there's no fetal anomalies. But it makes me laugh when I come in. I'm like, do you want to know the gender of the baby? And they're like, isn't that what we're here for? Well, yes. But also, well, we want to make sure there's arms and legs and the spine looks good and there's no heart defects and all this other stuff. And it's really not anybody's fault. They just don't know what all goes into our job. Obstetric sonography examinations typically diagnostic with respect to the fetal heart motion, fetal number, fetal biometry, fetal presentation, location of placenta, presence of maternal pelvic adnexal mass, and major disruption of fetal anatomy, such as anencephaly, which we'll talk about later, which is basically when the baby doesn't have a brain. Screening test does not provide definitive diagnosis, but indicates if patient or pregnancy at greater or lesser risk. An obstetric sonography examination with normal findings may reduce risk of that fetus having an anomaly, but does provide certainty that the fetus is not affected. So one of the things that we do, a disclaimer that we say is like everything from what we can see looks good, but ultrasound can't find everything. There's some things that are just not seen or developed later, just really difficult to see. So we can't 100% say a lot of the times that everything looks good, but we can give a higher, if we don't see any anomalies, it has a higher chance of being normal, if that makes sense. Okay, so this is the end of this chapter. Again, it was just an overview. I think they just did like an overview of what we are supposed to do when we scan an OB, like what is all involved, but now we'll dive deeper in the rest of this class and into OB2. So if a lot of the stuff was kind of confusing, don't lose heart because we'll go into each thing a little bit closer. All right, have a good week.